Good afternoon. This is going to be the audio portion of the lower airway conditions. So give me one moment and I will share my screen with you and we will talk about bronchitis, asthma, cystic fibrosis, and please excuse my voice. I've been talking a lot today. So you guys did a great job with the upper airway. It was great listening to your flip grids. You guys got a lot of good key takeaway points that could potentially be exam questions and also things that you need to know as a nurse. So let's get started. Objectives, talking about asthma, acute respiratory illnesses, cystic fibrosis, teaching plans, and then looking again at the airway. You notice the other lecture was dealing with the upper airway up here, and now we're going to move into the lower airway here. And so looking at ventilation, gas exchange, where the perfusion actually happens, are there enough red blood cells? But also keep in mind that upper and lower airways are linked together. So what happens in one section could affect the other section. So looking at a diagram here of the lower respiratory tract, these parts are found in the chest cavity. So you all remember your anatomy, the trachea, and then you go into the right main stem bronchus, left bronchus, the upper lobes, there's your middle lobe, right? And moving on down, primary, secondary, and tertiary, moving down into the alveoli, which are the actual lung tissue, and also the pleural membranes that encase the lungs. So what different diagnoses can you think of related to respiration, oxygenation, either upper or lower airway? I don't have any answers for this on the slide. I'm sure you can think of alteration in gas exchange, what else? Activity intolerance. You guys came up with a lot of these in your CRS as well. And some of them will apply to both the upper and the lower airway. Knowledge deficit is always a good standby as well. So when you're looking at the respiratory tract differences in children versus adults, we're going to do the same thing that we did for the upper airway. So for example, looking at where in a child, where the trachea and the bronchi are, you'll see that the trachea bifurcates or splits off at T3, where here in the adult, it splits off at T6. So it's up higher in the chest cavity. And the other thing to note is that the right main stem bronchus, which is this one over here, it has a steeper slope. I don't know if you can really make out the angle, but this one points down a little bit more and this one kind of points up a little bit more. It is more difficult to intubate when you're looking at it. It's harder to cut the corner, for example. And the same thing with suctioning. If you're trying to suction, you tend to go left instead of right. And so then it's difficult to clear out all the secretions. I love this slide. This is one of my favorite slides. So this is, again, differences in infants and children. So these numbers just astound me. So at birth, the lung tissue has about 25 million alveoli. By age 8, 300 million alveoli. And they continue to grow until puberty. So if you're looking at how many generations it takes, right? So here's the trachea, and then there's your bronchi, the segments, and then more subsets of bronchi. Then you get to your bronchioles. So if you're talking about bronchiolitis, this is what you're talking about is the bronchioles. Bronchitis is more up in this area. So these are bronchioles. And then these are the alveoli and the ducts. So when these collapse, that's when we talk about positive end airway pressure. We're trying to keep these alveoli open. And one of the things that helps to do that is surfactant. When you don't have enough surfactant, so you're talking about a preemie, then the alveoli collapse and it's very difficult to get them to open up. The surfactant keeps the surface tension on the alveoli so they stay open. So infants are obligatory nose breathers. They should be breathing through their noses. If they're not, you need to check for patency. Children often have an irregular breathing pattern. We talked about that, a little bit of apnea here and there. Respiratory rate higher. We talked about eustachian tubes being more horizontal than in adults. Immune systems are immature. That's why it's important to breastfeed. Smaller upper and lower airways in and of themselves. So if they would become congested, there's less space for the air to move through. And the supporting cartilage, the rib cage and some of the other cartilage there is not as developed. So let's see if our videos play here. So we have different conditions, acute bronchitis versus chronic bronchitis, and then COPD, bronchiolitis, which is RSV. So that kind of puts that in perspective for those of you that have had RSV patients, pneumonia, asthma, cystic fibrosis, and we're gonna have an example of stridor here. So let's go ahead. Let's see if we can play that when we'll listen to the doctors. All right, and then let's take a listen to this one. So that was an example of inspiratory, where'd it go? There we go, of inspiratory stridor as an example. I thought it was interesting in the doctor's video that when the people were coughing, they were coughing into their hands. So where should they be coughing? That just gives you an example of different types of coughs. And when you hear the different types of coughs, doesn't matter what how it's transmitted to other people, what would the isolation precautions need to be in order to protect yourself from those the viruses and the bacteria. Oops, let's keep going. Oops, sorry. There we go. So acute bronchitis, so that's the trachea and the bronchi in the upper respiratory. Following an upper respiratory infection, you can get it at any age, usually viral, sometimes bacterial. Tends to resolve in a couple weeks. You're treating the symptoms because it's an inflammation. Unless it was bacterial, then you'd have antibiotics. You're going to have that coarse, hacky cough, generally tends to be worse at night. Sometimes from coughing so hard, you can have chest and rib pain. You'll hear bronchi, crackles versus coarse bronchi. The terms kind of keep changing, so I don't necessarily say bronchi. I might say coarse because some people might not know what that means, or I might say a wet type of cough, or there's the breath sounds are moist. That's another good one. Now, bronchiolitis, it's usually caused by RSV. It can affect children by age 2, even sometimes a little bit older, but it's generally seen in infants less than a year. And we might get exposed to it, but to us, it's not very serious. You can get reinfected. It's generally the winter months, although after having done your research from last week, you looked at the seasons, you looked at why Florida is different, which there's really not an answer for that, why their season is pretty much all year round. But we generally go, they say November to March. Last year was through about April or May, and my guess is that it'll probably continue that way this season as well. RSV can, like immunocompromised babies can die from RSV, as you saw in the statistics that were presented. So here is a diagram of that. You get the obstructed airways that allow the air in, but because there's a lot of mucus and swelling, it's very difficult to exhale. So you get wheezing and crackles. You also can get some collapsing of the lung, air trapping, and so the whole respiratory process is just not working the way that it's supposed to. You can see the in this picture the mucus and the inflamed bronchial wall. And so direct contact, indirectly, hands to mucous membranes, indirectly by contact with surfaces. It can survive greater than 6 hours on a non-porous surface or on skin or paper for up to 1 hour. 4 days incubation, and usually 5 days is the duration. Although I think generally we see that peak maybe day 3 to 5, and then resolve or doing better day 7. Again, each child is individual. Might start with a cold, mild fever. You have clear discharge, which then becomes thick. The wheezing, the crackles, child is just not moving the air. You're going to see increased heart rate, increased respiratory rate because the child's working the increased work of breathing. The child's working harder. Again, they're irritable. They can't eat. It's hard to eat when you can't breathe. And then they're in respiratory stress and might have true apnea that they're not able to self-resolve. And you can do the nasopharyngeal swab, RSV, a rapid RSV. That usually comes back pretty quickly, and it will come back as positive. So prevention is everything, hand hygiene. Synergists, you did your research again last week, and so you have all the information on that. And then moving on to pneumonia. So you get a lung that's inflamed, which is where the gas transfer takes place, and so the gas doesn't transfer into the oxygen and oxygenate the way that it's supposed to. Very common in very young and very old. You can generally treat with oral antibiotics at home. However, in the elderly, a lot of times they'll have to be hospitalized, and in the babies as well. Risk factors for children would be chronic lung disease, so a preemie, bronchopulmonary dysplasia, if there's specific anatomic problems, gastroesophageal reflux with aspiration, that's a big one. So sometimes when you get those BRUEs, the brief resolved unexplained events. Maybe it was reflux and then they aspirated it. So you might see that. Sometimes in neurological disorders, immune status is compromised, and also exposure to secondhand smoke. So you can have pneumonia with RSV, which is viral, and so you're going to treat the symptoms. That's generally the cause, as well as influenza in the infants and children less than 5. If it's bacterial, oftentimes it'll be strep pneumonia. It could be Hib, Staph aureus. Could also be Group B and chlamydia. Sometimes you see that in newborns. And then if the alveoli become filled with pus as a result, then you get areas of consolidation where there's no air movement because the air's trying to move through pus. So different clinical manifestations that you might see, again, onset with an upper respiratory infection, generally a fever, dyspnea, difficulty breathing, tachypnea, increased respiratory rate, fine crackles, so little itty bitty crackles, not like crumpling up paper. Diminished breath sounds, you can't hear the air moving. Often a productive cough, and it's purulent, pussy. Chest pain from the coughing, often very tired, you get a sore throat, and sometimes you'll even have nausea and vomiting. So different diagnostic tests that you can perform for lower respiratory conditions. Some of these are the same that you would see in upper respiratory. You're going to get blood work. You would expect the CBC, which would be testing for, hopefully you filled in that blank, looking at white blood cells, CRP, C-reactive protein, which checks for inflammation, right? That can be a indicator of infection, as well as procalcitonin. Procalcitonin is an indicator or marker also for inflammation, but more in the sense of sepsis. So they look at that, it's a precursor to the calcitonin, sorry, and it can identify whether or not there is a bacterial infection. So oftentimes in babies, that's a good indicator. Urine and blood cultures, might do swabs, nasopharyngeal swabs, chest x-rays, and then gastric washing for acid-fast bacilli. So this is a test for tuberculosis. If the patient is not producing sputum at that particular point in time, then you can do a gastric wash, lavage, to look for those bacilli. So there is an x-ray, and on the right side is pretty much what it's supposed to look like. I'm not even sure, I can barely make out the heart, and this is consolidation. It's very difficult to move air through that. So collaborative care, things that you would see done or that you would be a part of. So antibiotics, if it's bacteria. Sometimes they'll do an antibiotic if it's RSV, if they think that the patient has pneumonia, because you could have a secondary pneumonia. We actually also, I think we had 2 patients that had RSV who did also have otitis media, and so I believe they were on amoxicillin. And then also, if there's an increase in WBCs, there might be a viral infection. So you might see an antibiotic even though it's a viral infection. Tylenol. Most of these patients, you guys that have been in peds, droplet in contact. And it is a pain, but it protects you and it protects the patient. So if they're coughing a lot, teach them how to splint like with a pillow or their hands, splint the chest when coughing. And then you want them to be moving air as much as possible. So any type of deep breathing or maybe an incentive spirometer might be helpful. And then vaccines, the Prevnar 13. Also in the video, they talked about for pertussis, the DTaP and Tdap, so those are important. I hope that you can see now that these conditions can be life-threatening for children as well as adults, and the vaccines have really helped decrease the incidence. So speaking of pertussis, It generally has there's generally like 3 stages, 3 parts to it. Can last anywhere from 4 to 12 weeks on average. So the first stage is called the Catarrhal stage, where you get the inflammation of the mucous membranes. And then you get, sorry, drinking my water. Then you get the paroxysmal stage, where you have the sudden recurrence or intensification of the symptoms, where you get that terrible cough, and it's very difficult for the children to breathe because you can't catch your breath. And then the convalescent stage, where the patient is recovering. So those are the latest statistics. I'm sorry, I should probably get more recent statistics, but less than 6 months to 19 years, 14,000 cases in 2016, and 7 deaths from a disease that you could have been vaccinated for. Now, it doesn't state that that's why they died. I'm not saying that. But almost 4,000 children in 2016 were not vaccinated in the less than 6 months to 6 years category. That's also why when there's a new baby, why the mom makes sure the dad, maybe the grandparents, anybody that's going to come in contact with the infant receives the Tdap for the pertussis component. So there are some statistics there. You can see how it was very prevalent, oh gosh, in the 1930s, and then now as we've gone 1990, you know, the DTaP and Tdap came out, and then we're on the rise again because people aren't necessarily immunizing their children. Again, another table with statistics. The paroxysmal cough, that's that barking, the whooping cough. Not generally a fever. There's really no systemic illness. It's just more inflammation. And then they cough so hard that they potentially vomit, and they could aspirate that. And then they have that whoop kind of sound. Adults often will have a choking sensation because, again, you can't catch your breath, and often some sweating episodes. I'm going to play this little video here. I'm not going to have it go too long because it just makes me cry every time that I that I play it, but just so you can hear the effect. Right, and so she can't catch her breath, little color change there. And then this video goes about 2 minutes, 2 minutes and 23 seconds, and that's how long this episode is. So then she gets upset and she starts crying, and we kind of start all over again. You also notice that she has an NG tube in, so she's probably having difficulty feeding, and so they have inserted an NG tube so that she can get some nutrition. Oops, sorry. There we go. So here is a visual of the incubation, which can be up to 21 days. Then you get the onset, that sort of inflammation stage, and then the coughing paroxysmal stage, and then that convalescent stage, which can be, weeks to months. So Tdap generally, that's the one in 7th grade, before entering 7th grade, so 11 to 12 years of age. You know, put in the they want the Tdap to replace the tetanus diphtheria for ages 11 to 64. And again, the adults in contact with young infants, so the pregnant women, healthcare workers, the parents, siblings, grandparents, and there's no defined minimum interval. So you could, for example, like even with just the tetanus, you can go back every year, not that you'd want to, but say, for example, the woman was pregnant, had the baby, and then 2 years later had another baby, everybody would receive the Tdap again, or could choose to receive the Tdap again. All right, moving on to asthma. So you guys know about that. We did that in CRS. It's, chronic recurrent obstruction might be partially or completely reversible. It is usually lifelong. Exercise-induced asthma sometimes can fade away, and it may not necessarily present as asthma, but you may have like a chronic bronchitis, something like that, as a sort of a sequelae from having it when you were younger. It's multifactorial. There is potentially a genetic predisposition. We have that picture in the upper airway of the child that puts their hand up against their nose, that allergic salute. And then you can also, dermatitis or eczema can be linked to asthma. So oftentimes they'll go hand in hand. So this is a classification. I did get more current statistics. 2018 was the most current year I could get. When you're looking at this on your own, this is a link to the CDC asthma site. So you can click on that and it will take you there. So it tells us that in 2016, for children under 18 years, it was 8.4% had asthma, and then it was 7.5 2 years later. So that is a decrease. Generally tends to affect females greater than males. The poorer you are, the more likely to have asthma. Why do you think that would be? What sort of factors can you think of that might affect that? Increased risk for obesity, family history, allergy, smoking. And then it does look like the deaths in 2015 was 3615, and then it decreased to 3518 and 3441. So there is a decrease. But the cost in 2018 for medical expenses, medications, as well as indirect costs like missing work or school days, like a parent that has to stay home, $80 billion just for asthma. That just is mind-boggling to me. So different triggers. I actually got this acronym from my CRS group, yay, as to a way to help you remember the different types of asthma triggers out there. So A is allergens, could be medications, pollen, food, sports-induced smoking, passive smoke, temperature, right? Sometimes the weather, humidity, or cold air. Different hazards like pollutants, chemicals, perfumes, right? That's why they kind of tell you don't wear perfume in clinical or cologne. M is for microbes, so anything viral or bacterial. Dust mites, cockroaches, mold, pet dander. And then anxiety or emotions like laughing or crying, shouting sometimes can be a trigger for asthma. So chronic asthma is associated with eczema, which I said earlier. It kind of gets itchy and then you get the rash. Allergic rhinitis, the coughing at night or with exercise with cold air, coughing when laughing, like you laugh too hard and you start to cough. Sometimes cold foods can trigger it as well. And another key point would be that it's not necessary to wheeze to be diagnosed for asthma. I think we actually talked about this in CRS, or was in the CRS packet, is that the pulmonary function testing is what determines the diagnosis. There are specific guidelines for that. So you may or may not wheeze at any particular given time, but based on your pulmonary function testing, that's what will give you the diagnosis. So here's what happens in an acute exacerbation, like an asthma attack, the typical one that you hear about. You get a constriction, there's a bronchospasm, swelling, and then you get secretions and mucus, and then swelling. So you can see this is normal right here. So there's, it's smooth muscle, it's open. You can see where air is going to be able to pass through. These alveoli here are open and look pretty well aerated. The bands around the bronchi are not constricted. Those are smooth muscle bands. And then you can see here with the asthma episode that because of the secretions and mucus, there we go, that you get the constriction of the smooth muscles. So not only in here does the opening close up to where there's more, right, you have increased resistance because it's harder for air to get in and out, but you also have constriction of the smooth muscle around the bronchioles, bronchi and bronchioles. So that's constricting it even more. Plus you have the mucus secretions, and then you also start to see here, these are collapsed alveoli, and so you don't have enough surface area to do the gas exchange. So that's what that looks like. Really pretty scary. And so the cough, the congestion, the wheezing worsens. It gets it's on expiration. It becomes very prolonged because it's hard to breathe. So it'll kind of be like a they'll breathe in, and then when they breathe out, it ends up being prolonged. Less airflow. You might have a tight chest, shortness of breath. A lot of times people will say they feel really tight in the chest. We even, listening to breath sounds, sometimes will say they sound tight because they're not moving air very well. And then when you do the med nebs, like we had a duo neb in the CRS packet, because it's what type of medication, like say albuterol or the petroleum bromide or Atrovent, because it's a fight or flight, right? And so they get kind of wide-eyed, get agitated, the pulse goes up. You can also become lethargic and irritable, like after. It's a cumulative effect of having these continuous med nebs. They can be up to every hour. And then when you are in respiratory distress and you've used a bronchodilator, sometimes you don't have an improvement. Sometimes you have to intubate. And hopefully the person has been taking their regular long-term medications. So different lab and diagnostic procedures for asthma. This is allergy testing, allergy skin testing. You can also use the ELISA enzyme-linked immunosorbent assay. You can look that up in your book. Pulmonary function testing, like we said, is the gold standard. You can culture the sputum. You can do CT scans, chest X-ray, lab work. You can also do check O2 sats and ABGs. I think you notice for RSV as well, the sats kind of run a little bit lower till it resolves, and the same thing would be true with asthma, till the airways open up more. So here is a diagram of pulmonary function testing, diagnostic for asthma, forced vital capacity. You guys can read up on that. And then this would be the diagnostic criteria. And so I have a couple pictures here. This is actually a video. So you can start doing the testing about 5 years old. You might be able to get a 4-year-old, depending if they can cooperate, because they have to put their mouth around the tube and breathe a certain way. We had a patient in clinicals who was developmentally delayed, and it was very difficult. The respiratory therapist kept trying to teach them, and it just was not working. And then you also have your peak flow meter, which you know about. So let's look at, so the pulmonary testing, I'll start it. It's like 5 minutes. You guys can look at it more on your own time, but this actually walks you through, and I believe they're in Scotland. They're adorable. And it actually walks you through the little girl getting several of the different pulmonary function tests. And the tech does a very nice job of explaining everything and putting the girl at ease. So that's why I thought it was a good example. So here are more nursing diagnoses, client problems, if you will. Ineffective airway clearance, right, due to the mucus and the swelling. Anxiety, right, because if you can't breathe, you get very, very anxious. The nursing care plans can be found in McKinney on those pages. Always deficient knowledge is a good fallback. And you can do gas exchange, ineffective breathing pattern, any of those types of things. And your goal, right, the goal needs to be specific and measurable. So maybe you're trying to decrease their anxiety, so their sense of panic. And so you know, the goal would be, these are actually interventions. Stay with the patient, slow breathing with the pursed lips, position them comfortably. So those are the interventions that you would do. Maybe the patient would state, the goal would be the patient states they no longer feel anxious after 10 minutes or by the end of your shift. And then different collaborative care. Ooh, back to the medications. I told you we would come back to this, the beta agonists. So bronchodilators, or the short-acting beta-2 agonists, the SABAs, short-acting beta agonists, are your rescue meds. So Prevento, which is albuterol, Xopenex is another one. And those both can come in MDIs, in the meter dose inhalers, or as medication nebulizers. And then you have your anticholinergics. There's the, ooh, that's spelled incorrectly, ipratropium bromide, and it lasts a little bit longer, up to 4 to 6 hours. Combivent is when you have the Atrovent with the albuterol. Combivent is the MDI, Duoneb is the nebulizer name. You could also use the corticosteroids. So I believe in the CRS packet it was Orapred. Prelone is another one. There are forms of prednisone. So you can do, a lot of times you'll see Solumedrol if the patient has IV access. Otherwise, there's usually a prednisone pack. It's a tapered dose. You start at a higher dose, and then each day move down to a little bit lower dose until you're done with the medication. This is just a slide that I put in. If you follow the link, this is a link here that tells you that there is now one inhaler that has actually 3 different types of medications in it. So it has the corticosteroid, it has a long-acting beta-2 adrenergic agonist, but it also has this muscarinic antagonist. So I thought if you wanted to look up that that site, that would be of interest. No test questions on that one. Just thought it was interesting, and it actually happened to pop up in my email when I was finishing putting the PowerPoint together, so that's why I added it. So table 29.4, collaborative care, you know, the drugs, the asthma action plans, you guys know about those. Looking at the pulse oximeters, you guys will go into ABGs more in 3rd semester. IV oral corticosteroids. And again, what are you worried about with corticosteroids? What happens when the patient is taking corticosteroids? Right? Immunocompromised, yes. And then what happens to the blood glucose? It tends to increase when the patient is on corticosteroids. So you want to be aware of that. Okay, so then this is a visual for how you might manage asthma. And so if you have intermittent asthma, it tells you, you know, consult with your specialist. You know, that you're going to, step 1 is using a short-acting beta agonist, and then moving it up. I have not seen theophylline used in a long time. So the ICS is the inhaled corticosteroid. And then there's combinations, and you just keep moving up the chain. Step down if you can, and if the asthma is well controlled, then you can back off on the medication steps. So you have inhaled steroids. So now we're talking about controller meds, like your regular long-term meds. So before was rescue meds, and now we're moving on to talk about like your daily routine asthma medications. So inhaled steroids like Flovent or Pulmicort, budesonide, those would be steroids. You might have Ceravent or Formoterol, which is Foradel. Then you can also have, which you guys are probably pretty familiar with, Advair and Symbicort. So these are combined long-acting with inhaled steroids. So the Advair is Salmeterol with fluticasone, and the Symbicort is Formoterol with budesonide. And then other controllers. So remember the leukotrienes are one of the things that are affected with asthma. So Singulair can help. Again, theophylline I have not seen in a long time. And then if you can decrease the triggers, so like allergy injections, right? That's one of the first things to do to help control exacerbations, is to understand what your patient's triggers are, because then you can hopefully avoid them and then not have the asthma attacks. There are some monoclonal antibodies, but those are very, very expensive, and I honestly don't know too much about those. And then planning, looking at your overall goals. You want to maintain a greater than 80% of your pulmonary function tests, and hopefully have minimal symptoms, not very frequently, no effects from medications, and not have recurrent exacerbations, or you want to see a decreased incidence of the asthma attacks. I think it's really important. I know one of my clinical groups was talking about cystic fibrosis, and they mentioned it on the flip grids, that in choosing activities for the children, we wanted to say, oh, do this, do that, don't do this, don't do that. And I think it's important for the children and the families to be able to choose the activities, but understand what the restrictions or the pros and cons, like have the whole entire picture available when making that decision. So, oops, my bad. One moment, please. Last viewed. There we go. So, nursing interventions, ambulatory and home care. So those would actually be goals if the child will, or the parent will, administer the medication appropriately on time. Be able to, the child will be able to describe the difference between the rescue inhaler and the maintenance inhaler. The child and or parent will be able to explain their asthma action plan, will know when to call the doctor, will know what it means to be in the red zone versus the yellow zone. Will be able to identify 2 activities that they can participate in without exacerbating the asthma. Those would be goals. And then so the interventions that you would do, again, education, as you guys said with your flip grids, a lot of education and repeat education, as well as having, I think they need to demonstrate back, to you that they understand, or teach back to you that they understand. Because oftentimes you send them home, especially in a clinic setting. Oh my gosh. So you see recurrent admissions because the parent didn't understand or the child didn't understand. And so it's just re-education. So follow-up care, if the asthma is in control, it's all good. This little girl down here, she's so cute. So remember we talked about spacers, or we did spacers a little bit in my CRS group, in our CRS groups, and this is the little mask that can be added to the spacer, as opposed to trying to put your mouth around the mouthpiece. So that looks like he has a spacer with the mouthpiece, and then that would be a handheld nebulizer treatment. You can also have these, sometimes I have the masks that go over their head to help keep them in place. And sometimes they have even little like dinosaur masks, things like that, to get the kids to be compliant. So this is an example of an asthma action plan. You guys have seen that and worked with teaching it to different people. So just understand the why you use it, what the differences between the green, yellow, and red zones are. And everybody's is individualized, right? Because you're going off peak flow meter readings. All right, moving on to cystic fibrosis. It's a genetic disease. It's lethal in Caucasians. You generally see it in Northern Central European Caucasians. Both parents have to carry the gene, 25% chance of producing an affected child. So it's an autosomal recessive trait, usually diagnosed before the child's 2 years old. But in 2007, one of the nice things is that it became, in California, became one of the newborn genetic testing screen, the metabolic screening that's done, they added cystic fibrosis to that screening. So if you think about it, that's done prior to discharge from the hospital after the baby's born. Usually comes back in a week, maybe 2 weeks, the results. And so you're able to detect it much, much earlier, which means you can start some measures and treatments that will help prolong the life, hopefully a little bit, and make it a little bit easier for the child. So you get an increased thickness. Viscosity is like thickness of the mucus in the gland secretion. And the thing is that it's not just the lungs where you have the secretions, but you also are having pancreas issues, and then that leads to digestive and nutritional problems that can happen. So, excuse me, the mucoprotein, this thick mucus, tends to form in the gland. So you've got the pancreas, right? And so if it blocks the pancreas, what is the pancreas? What is one of its functions? Right? It has enzymes. It sends out enzymes. It helps with, depending on which cells, helps with insulin production. And so if those are affected, then there's issues with digestion. And then here you can see the mucus in the alveoli, right, which we're wanting to keep open, so for air exchange. And so it's very difficult to have good air exchange. So this is a little schematic, I guess. So you have, if you have up at the top cystic fibrosis, and you get the gland dysfunction, so you get this buildup of mucus, secretion and obstruction. So you have extra mucus being secreted, and then it makes an obstruction. And the thing is that yes, it affects the lungs. So it affects the bronchi. There's obstruction. You can get pneumonia. You can get emphysema. But then not only does it affect the bronchi, but then it also affects the small intestine. One of the key things in a baby is if they remember, we talked about when do they have their first urine, when do they have their first meconium. If you don't have meconium within the first 24 to 48 hours, it could be because the child has cystic fibrosis, because there could already be an intestinal obstruction in the newborn. So that's why that's an important assessment to make in the newborn. There's also affecting of the pancreatic ducts. So you can have malabsorption syndrome, so nutrients that come in don't get absorbed appropriately. So that leads to nutritional deficits. And then also in the bile ducts, you get fibrosis. Concretions is like it gets hardened. And then you can have cirrhosis and portal hypertension. So now you've got hypertension in the bile ducts, which is bile. It's just secretions, and it's just it's a terrible disease. So diagnostic procedures, you could potentially find out in prenatal testing with an amniocentesis or chorionic, that is spelled incorrectly as well, chorionic villus sampling, the newborn screening, if you do DNA testing. Later on, you could, with chest x-rays, you might have some atelectasis, collapsing of the lungs, or obstruction. Pulmonary function testing can lead you to that diagnosis. Also, fecal fat analysis, liver function tests, glucose testing, and then you can also determine pancreatic enzymes, how many pancreatic enzymes are there. The sweat chloride is pretty much the initial way, I guess, the sweat chloride test that you've heard of. And so if there's sweat is produced, and there's like salty, remember you would kiss, if one of the things was like if you kissed the child on the forehead and they tasted salty, then they probably had cystic fibrosis. That was kind of like an old, I don't know, not wives' tale, but that was something that back in the day before you had all these diagnostic tests. And if they have sodium chloride greater than the 60 milliequivalents per liter, then that's suggestive for cystic fibrosis. The sweat chloride is not the be-all end-all. You have to kind of do the other testing as well. unless you do genetic testing and you get the 2 mutations, then you know that that they have cystic fibrosis. So looking at respirations, the barrel chest, they might have the barrel chest similar to what we have with COPD, remember last semester. Their oxygen saturation is a normal low saturation. So similar to COPD, right, where their baseline might be at 88% on room air, you need to find out what the patient's baseline is so you know where they are. There could be clubbing of the fingers and toes, tired a lot, irritable, because if I felt that way, I'd be irritable too. Often very pale, could have some cyanosis, shortness of breath, thick secretions, wheezing, coarse crackles, and usually a moist and productive chronic cough. So trying to maintain respiratory function would be one of the goals. You want to try and reduce the sputum thickness, improve the function, being able to move air through the airways. So Dornase alpha, Pulmozyme, is a medication that can help do that. Hypertonic saline can help with hydration. Sometimes the bronchodilators help, but sometimes the side effects are pretty bad. NSAIDs, steroids. If they have sinusitis, you can do the saline irrigations. Immunocompromised, they're immunocompromised, so any immunizations, keeping them away from people that are sick, all that kind of stuff is very, very important. So they are susceptible to Pseudomonas infections, and so you can do antibiotics IV. There's also some inhaled nebulizer treatments where you can put like tobramycin in it, and so they're actually inhaling the antibiotic. That's tobramycin. They're inhaling the medication in the aerosolized nebulizer treatment, in addition to maybe IV antibiotics. So then collaborative care, working with respiratory therapy, so chest percussion, chest physical therapy, that's what CPT is. Your book, I believe, shows you the different way. You don't want to do it over bones, and you want to do also postural drainage, so you put them on their side, on their front, on their back, in Trendelenburg, different positions while doing the chest physiotherapy. There's also positive expiratory pressure devices like a flutter, a cappella. I have pictures of that on the next slide, I believe. Deep breathing, controlled coughing, huff coughing. If you click on this is a link that takes you to an article and gives examples of huff coughing. There are also the high frequency chest wall oscillation systems. So this is like a vest system. They put the vest on, and then it actually like oscillates, vibrates to sort of take the place of the chest physiotherapy, and they can be in different positions to drain the different lobes of the lung and mobilize the secretions. I guess aerobic exercise would sort of accomplish the same thing, but I'm not sure that they would be able to do aerobic exercise on a regular basis, because that would make me really tired. So here's examples. This is the flutter device. This is what it looks like on the inside, and the mouthpiece, and then the flutter device. That's what an a cappella device looks like. And so it kind of it gives, what do I want to say, it's positive pressure, but also kind of like an oscillator as well, to kind of help break up the mucus. You might see the clubbing, we said, in the fingers or toes, because there's damage to the lungs. The right ventricle becomes enlarged. You can also get hypertension. So you're basically drowning in your own secretions, I guess would be one way to put it. That sounds kind of coarse, but that's kind of really what happens when you're looking at nutrition. So because of this, the thick secretions, the ducts are blocked, and so like here's your different. So this would be your liver. There's your gallbladder. There's the pancreas, right? There's you got the bile ducts in there, the head of the pancreas, the duodenum, so like intestine coming through there. And so what happens is the the ducts get clogged, and so the pancreatic enzymes can't get to the duodenum, right? Because you'd have these enzymes coming here to help break up food. There's malabsorption, and there's also the absorption of the fat and the protein are also inhibited and changed. So it's very difficult to have proper nutrition. So there are the enzymes, there's trypsinogen, lipase, amylase. They don't reach the intestine, so the foods don't get digested appropriately, and you don't absorb the nutrients. Really poor absorption of the fat-soluble vitamins because the fat is affected, so your ADEX, impaired salivation. You will see a decreased weight gain despite good appetite. So the pancreas is usually okay initially, but then over time, because of the secretions and the fibrosis, the patient then can develop diabetes mellitus, and then you can also get cirrhosis of the biliary ducts. So skin, looking at you're losing electrolytes in the sweat, and so you get that salty skin surface, and that would also include tears and saliva, and you get electrolyte imbalances, especially when there's hot weather. And so some of the things to do to promote optimal nutrition, like frequent small meals, perhaps. You want high calorie foods, 1.5 times the normal calories, 2 times the RDA protein and fat, because that's what they're losing. Oftentimes they have special formulas. They'll have TPN, total parenteral nutrition, or NG feedings, or G-tube feedings with high calorie formulas. You want water-soluble forms of the fat-soluble vitamins, iron. So I'll taking all these supplements, all these pills, the iron, the special formula, the pancreas enzymes. So you want to take that 30 minutes before eating a meal or snack. It's dependent on the frequency of stools, and it's independent to each patient. You can also put beads on non-acidic food, and use anti-GERD medications as well. Check your blood glucose, and sometimes they'll even check the growth hormone, because sometimes growth can be stunted. And then if you're trying to have normal peristalsis and get things moving through, the intestine, because everything sort of slows down because the enzymes aren't there to break everything up and get absorbed. So hopefully they can, the patient can exercise. You can use lactulose or fiber or increase fluids to kind of get things moving through the intestine. If there is an intestinal obstruction, hopefully an enema might be helpful. You could also do lavage by the NG tube. So you could put, so lavage is like laver in French, to wash. And so lavage would be putting the anisotonic fluid by NG tube into the stomach, and then so hopefully that could be kind of like a roto-rooter kind of thing. Or you can do the enema from the rectum the other direction. Neither one is pleasant. And the patients really get to know themselves. They really get to know what foods cause this, what activities, what they need to do or not do to maintain everything sort of at a status quo. They could have a distended abdomen due to the constipation. There could be an obstruction. You could get an enlarged liver. The stools, if you think about the 4 F's, bulky, foul-smelling stools, because the fat isn't digested. So it's frothy, foul, fatty stools that float. So when you're talking about floating stool, that's related to the cystic fibrosis. And then if there's an impaction, an obstruction, impaction, where the stool, the feces is so impacted it can't move out, you could the rectum could prolapse, which is not fun. So in the newborn, the thing that you want to look at, we talked about this earlier in terms of elimination, would be a meconium ileus, meaning that the meconium was up somewhere in the intestine and has not come out, and that happens because they don't have the enzymes and so it gets stuck, the meconium, which is already thick and black and icky looking, it ends up sticking to the walls of the intestine, and it's very difficult to move through. So a lot of times with infants, you'll also see failure to thrive due to the malabsorption. You can see fecal impaction and intussusception. We're going to talk about intussusception this week. Thin arms and legs, muscle wasting, perhaps short stature. And that's why we're checking the growth hormone as well. Sexuality, you'll often see delayed second sexual characteristics, delayed puberty in females, very difficult to, wait, that's spelled incorrectly as well. Difficulty with conception because of the mucus. If you think about it, so the cervical mucus that you normally have thins out when you ovulate, but because the mucus pretty much everywhere in the body is so thick, it's difficult for the sperm to get through the mucus, and then the males may also have a low sperm count. So emotional needs. So cystic fibrosis is a chronic disease. This would be one where when we talk about congenital anomalies, where parents aren't really necessarily expecting it, didn't know about it, and then all of a sudden, you know, a couple weeks after birth or a couple months after birth of the baby, they find out that there's this chronic disease, and probably their child won't live past 40. And they're gonna, you know, go through that whole grief process, the DABDA. There's really no cure at this point. There's a lot of research going into it. Support groups are really important for the client and the family. And really letting the patient and the family be able to manage the disease in a way that works for them. And so I'm trying to think, what else can I tell you? So this last slide, so I got permission from Julie. Julie is my college roommate's daughter, and this is her husband, Eli, and he passed away in 2017. Excuse me. And the really neat thing about their relationship, I think, in my experience and watching them go through all this, is that they were together for a really long time, and Julie knew that Eli had cystic fibrosis, and she really wanted to spend the rest of his life, you know, the life that he had left with him, and so they got married, and beautiful ceremony, and she became his caretaker. And I didn't get the have the honor of meeting him a couple times. Really nice guy, really smart, polite, just full of life and jokes. And but Julie would post pictures with his permission of some of the things that he was going through. And he looks pretty pale and thin there. It's not before his final battle, but pretty close to it. And so I asked her, would I be able to you know, post this picture in terms of being able to, you know, in his memory. And she said, yeah, that was fine. But just to sort of put a face with the disease process, and also, you know, reading Julie's post, having such a hard time the last few hours, grief and depression hits me so hard and out of the blue sometimes. So just to understand and be there for the family and the grief that they're going through. So hopefully that helped you understand RSV and asthma and cystic fibrosis a little better. So let me know if you have any questions. And that is the end of the PowerPoint. And so let me bring you back. Dun, dun, dun. Hi. And so let me know if you have any questions. Email me, and I'll see what I can do. So I will see you in the next lecture. Bye.